Okay. Welcome to Origins and Utility of Autoantibodies in Oncology. My name is Dr. Janique Peyper. I am a clinician scientist specializing in systems immunology. What I hope to achieve today in this presentation is to show you how the intersection between oncology and immunology can help us to enhance translation from bench to bedside. We'll be talking about a number of complex topics today. We'll start a little bit with how cancer is a complex disorder, a short overview of the immune system, how tumors can become immunogenic, how that can activate B cells, how antibodies produced by B cells then function, and ultimately how autoantibody profiling can be of use in oncology. Because of time constraints, I won't be able to cover any of these topics in any great detail. However, I do hope that combining these topics together will provide some light bulb moments for at least some of you. And I'm always available as well via email for follow-up if anyone has any additional questions. From a cellular and a molecular standpoint, the body is an extremely complex and dynamic biological system. Every health or disease phenotype reflects the multidirectional interaction between many body systems, each of which is composed of a number of layers, as you can see on the right-hand side of the slide. Accurately determining in vivo function of a component or of a biological system requires a move away from traditional reductionist or isolationist thinking and a move more towards systems biology thinking, as well as the associated advanced molecular omics technologies. We also need to consider how to rationally intervene in a complex disorder. For example, we need to consider how normal function was originally perverted, where along the pathogenic cascade it is most rational and beneficial to intervene, and also how we can start to shift the system away from progressive pathology and more back towards a sustainable equilibrium. Again, I'm probably preaching to the choir with this audience, but cancer is one of the most complex disorders. No two cancers are alike from a molecular perspective, and it is constantly changing. It really represents evolution on a rapid and micro scale. So trying to develop therapeutics or effective therapeutics for an established cancer is frustratingly like trying to close the barn door after the horse has bolted. However, cancer is especially linked to the immune system, and examining a directly functional molecule like an antibody of the immune system can really provide us with a glimpse into what the immune system has already seen and the decisions that the immune system has already made. This window onto normal functioning and pathogenic functioning really enables us to enhance the translation from bench to bedside. The immune system consists of a large number of functionally plastic cells and an even larger number of soluble messengers and their receptors. This system can really be thought of as an extremely complex if-then algorithm, and it is constantly surveilling both the intra and the extracellular space for abnormality. There are a finite number of stimuli or stimuli types that will activate a unique set of pattern recognition receptors, which ultimately determines the stimulus-tailored immune subroutine that becomes activated. While some of these subroutines can act together and can even synergize, the simultaneous activation of others is aberrant and counterproductive. The subroutine that's considered most effective in tumor immunology is the Th1 or cytotoxic program, which aims to correct intracellular abnormalities. This type of program typically results in the production of IgG1 and IgG3, but IgM and IgA can, of course, also be produced. Given that the tumor consists of host and self, how is it that it can be immunogenic? It turns out that tumors have an array of mechanisms by which they can become immunogenic, although, of course, certain tumors will also have an array of mechanisms by which they suppress immunity. And that is typically in tumors that are at a later stage of their progression. So let me give you some examples of how tumors can become immunogenic. If you look at the table on the left-hand side of the slide, you'll see TAA, that's tumor-associated antigens, which consist of unaltered self. This can result from mechanisms such as overexpression, underexpression, ectopic expression, for example, at the wrong time or in the wrong compartment, molecular mimicry, excessive or prolonged inflammation, metabolic stress, or cell death. It's also possible that there might be subversion of housekeeping autoreactivity. However, the evidence for that is not yet direct. Mechanisms like epitope and antigen spreading are likely also involved. Then if we move on to the bottom part of the table, tumor-specific antigens, these are altered self molecules. They are generated by gene mutation, aberrant enzymatic post-translational modifications, aberrant proteolysis, non-enzymatic modifications, misfolding, and also oncogenic viruses. Certain tumor antigens are so prevalent across tumors that they're known as universal antigens, and unsurprisingly, these are the ones that are typically resulting from very common tumor driver mutations, as well as from oncofetal and cancer testis antigens that the tumor begins to express as it acquires progressive stemness characteristics. Although there is a very large inter-individual variability in autoantibody profiles, which typically requires a slightly larger sample size to be able to achieve discriminatory power in studies, it is also true that individual profiles are very stable over time. And so it is possible that the ultimate focus of precision medicine in this space will focus more on looking at individuals over time. Just to drive the point about complexity home a little bit further, I've also included this particular publication, which shows that molecular mimicry from microbes can also influence the interaction between the tumor and the immune system. This particular publication talks about viruses. However, it's not limited to viruses. It can be any microbe, including the commensal flora. All right, so now that we know that tumors can be immunogenic, how do they activate B cells? What are the mechanisms? The first step in activating B cells is antigen encounter. This can occur either in local tissues or it can occur in secondary lymphoid organs, such as the lymph nodes, which monitor tissue fluids, or the spleen, which monitors blood. Unlike T cells, or adaptive T cells rather, which are limited to recognizing proteinaceous antigens which are presented in a very specific context, B cells are quite happy to recognize antigens in almost any way. They can recognize antigens presented by any type of cell, body cell. They can also recognize antigens presented by antigen-presenting cells, or they can recognize the antigen just in its normal natural conformation. All right, so I want to draw attention here to the fact that the antigenic universe is inconceivably large. It goes far beyond just proteinaceous antigens. If you consider that receptors and antibodies typically bind the 3D conformational epitopes on 3D molecules, it really is amazing. It's a minor miracle that we even can achieve tolerance and that molecular mimicry isn't more common. All right, 2 in B cell activation. Once B cells have encountered the antigen, they will typically take up that antigen, process it, and display it on their surface. This allows them then to go and confer with nearby T cells, whether of the innate or the adaptive system, to try and generate some kind of consensus and to see, in this particular context, is it worth activating and is it appropriate to activate? I want to draw attention, as I've said previously, that adaptive T cells are really limited in which types of antigen they can recognize. You can see that at the bottom part of this table. Whereas innate T cells and B cells really are not restricted by that kind of antigen. They don't have to see protein antigens that are being presented. They can recognize almost any class of antigen. Finally, B cells will appropriately activated B cells will become plasma cells that secrete antibodies that are specific for the original inciting antigen. How well the B cell has immunologically synapsed with the T cell will determine the quality of antibody response. So if you started off with a low affinity antigen, then the synapse between the T cell and the B cell may be quite short and sort of incomplete. And so that will clearly influence the quality of your response. However, in all responses, within hours, your B cells will start producing relatively low affinity antibodies of various isotypes outside of the B cell follicles. Within days, B cells will start producing moderate affinity antibodies of various isotypes, also produced outside of the B cell follicle. And within weeks, B cells that have entered the follicular germinal center and undergone somatic hypermutation-mediated affinity maturation will start producing high affinity antibodies of various isotypes. These antibodies can be secreted either in local tissues or again in secondary lymphoid organs. The most high affinity cells will then go on to seed the memory B cell and the long-lived plasma cell populations for sustained protection. It's important to note here that what I've discussed is a primary response. So that is activation of a naive B cell. It is seeing the antigen for the first time. In the context of an established tumor, you would definitely have primary responses occurring, but you would also have memory B cell responses occurring. And the activation mechanics and kinetics of memory B cells are different from those of naive cells. So it's just important to remember that when you're thinking about this kind of situation. Obviously, in presentations, you try and make the picture as clear as possible, but actually there are many overlapping and overlaying responses occurring simultaneously. Okay, so just turning back for a moment towards follicles, B cell follicles. B cell follicles are really clusters of B cells with a very specialized architecture that facilitates full B cell activation. Okay, so knowing that, and now I want to turn your attention to the idea of chronic inflammation. Normal inflammation is brief and effective. It will remove the inciting stimulus, clear the debris, and allow healing and tissue homeostasis to occur. By that definition, any prolonged or chronic inflammation is abnormal and will ultimately derange the immune subroutines and their regulatory circuits. And that includes the type of chronic inflammation that occurs in a cancer setting. Having said that, there are some tissues which experience chronic or tonic antigen stimulation in a normal setting. And these include things like your mucosal membranes as well as your skin. Because of that constant antigenic stimulation, these tissues end up developing what is known as secondary lymphoid tissue, which is characterized by the presence of lymphoid follicles, so that B cells can be locally more rapidly and fully activated. However, this normal mechanism of secondary lymphoid tissue arising can be perverted in cases where tissues are experiencing autoimmunity, chronic infection, immunogenic tumors, or any other reason for chronic inflammation. That chronic inflammation ends up recapitulating the normal mechanisms that give rise to secondary lymphoid tissue and instead give rise to ectopic or tertiary lymphoid follicles or structures in that tissue, which can be either helpful or harmful in a context-dependent manner. Okay, let's take a brief tour of antibody functions now that we know how B cells are activated and that they secrete antibodies once they're activated. Antibodies can engage in neutralization, which is antibody agglutination of a target, which excludes the target from interacting in a damaging or an inflammatory way with a host body cell. Antibodies can also engage in opsonic phagocytosis. In this case, they coat the target and provide flags for myeloid phagocytes to come and take up that target and degrade the target internally. Antibodies can also mediate complement-mediated cytotoxicity. So the antibodies bind to the target, they fix complement on the surface of the target and activate complement, and can ultimately result in MAC-mediated lysis of the target. Antibodies can also lead to target cells degranulating. So, for example, cytotoxic granules can release their contents into the extracellular space. One of the newer mechanisms discovered for antibody functions is uptake of antibodies, resulting in intracellular activation via TRIM21 of antiviral responses and pyroptosis. Finally, via the balance of activating and inhibitory Fc receptors for antibodies, they can also have an additional array of effects on cell function. All right, so we mentioned earlier that the antibody subclasses that are thought to be most effective in anti-tumor responses are IgG3 and IgG1. And indeed, this is a sort of a general rule that isotype and subclass determine antibody functional specialization. Isotype is determined by the heavy chain of the antibody. So, for example, if the antibody has a mu heavy chain, it will be IgM. If the antibody has a gamma heavy chain, it will be IgG, and so forth. The subclass is determined by the antibody composition of the Fc region. Another general observation about how antibodies function is that each anatomical compartment, depending on the types of antigens that it typically sees, also has a particular pattern of antibody isotypes and subclasses that are usually present there that are sort of tailored to the needs of that particular compartment. However, all of the isotypes and subclasses do also end up in circulation. Apart from isotype and subclass, there are a number of other factors that can influence antibody function, such as post-translational modification, like glycosylation, for example, the balance of activating or inhibitory Fc receptors that are present on target cells. Where the antibody binds an epitope can also impact where the antibody then further goes on to bind complement or its receptor. And then there are a number of extrinsic factors such as the microenvironment, the immune context, and the timing along the disease continuum. All right, so hopefully, putting all of that information together, we can now start seeing how antibody profiling can be of use in an oncology setting. And really, there are myriad functions that autoantibody profiling can provide, all the way along the continuum from health to disease and treatment. So if you look at the slide, in terms of health, for example, they can help us understand normal across the lifespan. They can help us to identify conserved, protective, or risk-conferring autoantibodies. They can help us to rationally optimize health and prevent disease. If we move across to the sub or preclinical side of the slide, this is during research or preclinical disease. Autoantibodies can help us to understand the pathogenesis and also tumor evolution. They can help us to risk stratify and associate at-risk groups with genetic and environmental risk factors. They can help us to detect disease very earlier than we otherwise might have been able to. Clinically, during disease, again, we can identify protective or deleterious antibodies. We can stage disease using antibodies as a proxy for disease burden. We can prognosticate in many different ways. We can molecularly subtype diseases and tailor treatments to the correct subtype, as well as potentially developing companion diagnostics that help us to identify which subtype will benefit from which treatment. We can also identify novel treatment targets. Finally, during treatment, we can monitor the response to treatment. We can even use autoantibodies as surrogate endpoints for clinical trials in which the actual outcome or endpoint will happen years down the line. We can also help predict recurrence using autoantibodies. Okay, so now that I've told you in theory how they can be used, let's quickly look at a little applied example in the autoimmune space. So in 2018, Lewis et al. Looked at a large discovery cohort of nearly 200 lupus patients and 200 controls, as well as a validation cohort of nearly 100 lupus patients and 100 controls. Using these cohorts, they identified and validated 79 lupus discriminating autoantibodies, of which 68 were novel. These antibodies were also able to reveal 4 disease clusters with subgroups. And so these are what the subgroups look like on heat map. But not only did these subgroups exist based on autoantibodies, the subgroups actually correlated with clinical phenotype and reflected differing target molecular functions. So I hope this gives you an idea of the strength of this kind of approach. These subgroupings may reflect, for example, different points along the disease progression continuum, or they may reflect truly distinct pathogenic mechanisms that just give rise to a common clinical manifestation. But either way, it's extremely likely that those subgroups have differing capacities for responding to treatment or different treatments. So that was an autoimmune example, and I know we're interested in oncology here, so I'm just briefly going to give you some examples of oncology-based case studies, if you focus on the last 3 items in this table. So firstly, in early stage melanoma, melanoma versus controls were autoantibody profiled, and it turned out that an autoantibody panel was able to provide early detection of melanoma with 84% sensitivity and 79% specificity. This is an image from that paper showing the sum of the panel score between the melanoma patients and the healthy controls, and you can see there that there's a relatively clear distinction between the groups. Moving on to the next item in the table, non-small cell lung cancer. Here, autoantibody profiling was done pre-resection, and the patients were then followed up for at least 5 years for survival. And it turned out that an autoantibody panel was able to predict 5-year survival following resection with greater than 84% sensitivity and greater than 74% specificity. This is an image from a Kaplan-Meier survival curve from that publication, and you can clearly see here that high expression of the biomarkers in the panel correlate really well with lower survival, and low expression of the biomarkers within the panel correlate with high survival. Finally, if we look at later stage melanoma, in that case, the autoantibody profiling was done before immune checkpoint inhibition, and the patients were followed up for immune-related adverse events. And the antibody panel that resulted was able to predict immune checkpoint inhibitor-induced immune-related adverse events with greater than 90% sensitivity and greater than 90% specificity. Here is an image from that publication where you can clearly see that certain autoantibodies really do discriminate between classes, and at the lower set of images, the orange is the cases and the blue is the controls who didn't develop immune-related adverse events, and that so you can basically see the pattern for every single one of the antigenic targets. All right, that is the end of the presentation, and I'm happy to take any questions. Again, I'm also available via email for any questions you may have, either related to systems immunology or related to autoantibody utility in oncology.